I'm talking about the Baby-Friendly Hospital Initiative, and on my first slides I talk about the Baby-Friendly Hospital Initiative being a key component on maternal and newborn care, because sometimes the Baby-Friendly Hospital Initiatives finds itself misplaced. It's neither here nor there, no one is responsible, and therefore it's an initiative that is handily taken care of in a number of facilities. This is one of the initiatives that was established by WHO and UNICEF to look at protection and support for breastfeeding. And it has 10 key steps that needs to be put in place for us to talk about hospitals as being baby-friendly. It's a part of the global strategy for infant and young child nutrition goal, and looks at every facilities, how do they provide the maternity services that should be fully implement baby-friendly hospital initiative. So I'll skip this because I can tell it's quite a bit of what you have heard about, but I want to emphasize maybe the last part of it, the counseling mothers on risk of feeding, bottles, the teats and pacifiers and cups with spout. I'll expound on it a little bit more, but just to note that the early and uninterrupted skin to skin is quite key. Allow me to skip that. The reason as to why, I just want maybe to emphasize the second point. The risk of dying in the first 28 days of life is 33% higher for newborns who are not initiated who initiate breastfeeding within 2 to 23 hours after birth, and more than twice as high for those who initiated 1 day or longer after birth, compared to newborns who are put on the breast within the first hour after birth. Allow me to take a minute or so here talk about the nutrition status of women. And why am I talking about the nutrition status of women when I'm talking about the baby-friendly hospital initiatives? It is because breastfeeding counseling should not start at delivery. It should not happen in the labor ward. It should not start when the mother has delivered the baby. That is too late an introduction. And just to note that what happens in a number of cases is that when mothers come for antenatal care, they do not get the counseling that they require about their own nutrition status. And when I talk about this, I'm more passionate about the adolescent mothers who even attends to them to tell them that you are an adolescent and you are also a mother to be. So, and therefore there's need for us to think about what exactly is happening for the pregnant mothers, whatever age they appear at the health facilities. And just to note, as a country, we are doing worse and worse with time. You can tell about the mean BMI for women of reproductive age. You can talk about the obesity that is getting higher and higher. So we have a few things that we need to think about. We can also tell that the micronutrient supplementation that has been a problem that has been learning over the years has not been doing very well. As it is right now, we know a few facilities have even moved from iron and folic acid supplementation and are recommending the multiple micronutrients. Please be careful which one you are recommending also, so that you give the women what is required for them. Some of them are very low in iron, while we know iron deficiency is quite common in the country. So let's target to meet the needs of the mothers at an early time and to let them know what is expected of them even before they come to the delivery. Allow me to skip that because it has been discussed quite a bit. Yeah, sorry, I talked about the maternal nutrition, and then the women of reproductive age. Allow me to skip this because it has been discussed quite a bit, but just to tell, neonatal mortality is still where we have to work on it. And the time to work on neonatal mortality is not during delivery. It should be done when the mother is pregnant or even before pregnancy, because some of those are things that we actually need to think about: family planning methods, the maternal nutrition status, delaying pregnancies for the young children, the young adolescents and all that, so that then we're able to address the neonatal mortality. Then I wanted to talk about this a little, just to say that the key indicators, you look at the fourth antenatal visit, there has been an improvement. You look at the 2022 data for the KDHS, more than 60% of these mothers had their fourth antenatal visits. So these are mothers who should have really benefited during their antenatal care on services, on the counseling, on what needs to be done. Besides that, look at the skill delivery. As a country, we are so proud we are getting to 90, we are at 89% skill delivery. But that skill delivery does not translate to early initiation to breastfeeding. Why doesn't it translate to early initiation to breastfeeding? We will talk about it in the next few slides. Neither does it translate to exclusive breastfeeding. I'll take minimal time on that because it has been said. And now talk about the 10 steps. And talk about the 10 steps in two categories, about the key management procedures, because I know quite a number of years are managers in one way or the other, and therefore we have a role to play as far as this is concerned. So there is need for us to think about the complying to the International Code of Marketing of Breast Milk. That's very important. Having a written infant feeding policy is also very important in every health facilities, public and private alike. It's very, very important because this is where we go wrong in a number of places where we allow the clinicians. There are no standard operating procedures in a number of health facilities. So it's about the clinician who is handling the mother and what they think and what they decide to do. And we should be very careful in quotes when we think about this as humans who do not have a voice, you know, and therefore they are treated in different ways because they do not have a voice. And the mothers sometimes are not even aware of why their children are treated in that. So having a very, very clear written policy and SOPs are very important. Then there is need for us to ensure we are having an ongoing monitoring and data management systems. I was so happy when you were talking about the monitoring in the morning session, because this is what will tell us what direction we are taking. As a country, if we had been keen on what exactly is happening and the monitoring, then you would have been able to advise. But we hardly are careful on how many of these mothers who are leaving the maternity ward have started breastfeeding. How is it going? Did anyone observe the breastfeed? Who was it that observed that breastfeed? What is the continuation of the care and such that is going to happen at that facility? The next steps here we are failing quite strongly as a country, and we need to work on. Ensure that staffs have sufficient knowledge. Knowledge may be there, but we are very poor in looking at the competences on the ability of the healthcare workers to support breastfeeding. We have very limited numbers who can confidently support breastfeeding in the country. And therefore, because we know and we don't have the confidence to support, people tend to give information. So it's usual for mothers to be told, breastfeed your baby exclusively. And so they get to know that. But how do you do it? Then that is not given to them. What if you have difficulties? The many challenges that they face when they are breastfeeding is never described to these mothers. So they find themselves always struggling on what needs to be done for them to continue with breastfeeding. So we need to be very careful on ensuring that they have the knowledge, but also besides the knowledge, then they also have the support that they require. Step number 3, I'll just go over this quite fast. The importance and management of breastfeeding should be done with pregnant mothers and their families. It is not one of those things that are budgeted for as far as time is concerned in most of the antenatal care work for the population. So let's see who does it anyway, by the way. Just try and think of where you do your clinical practices. Who does this? Is it anyone's responsibility? Because if it's not, then it is not done. Then the facilitation of immediate uninterrupted care is also one of the things that we need to be sure about. And the support to initiate and maintain breastfeeding and manage the common difficulties. No one deals with mothers who have common difficulties because they at first have not even learned how to do the breastfeeding at the health facility. So you may not even know. The mothers go to learn when they are back home that they are having this or the other challenge because they never had a chance to interact. They never had a chance to be trained and to get the skill on breastfeeding. The provision of other foods and fluids is quite common. While we know we should not provide the newborns with any foods or fluid other than breast milk unless medically indicated, it's very common that you see so many of our healthcare facilities introducing other feeds to the children in the name of many, many different things, but we need to be careful that that does not spoil the work that we are doing at the health facilities. enabling the mother and their infants to remain together and to practice rooming in. We should just even check our public health systems. Who takes care of the children in the newborn unit? How often do the mothers have contact with them? How much Kagalu mother care are we doing as a country? Because these are some of the things that we need to emphasize and work on. And these are some of the reasons as to why we see breastfeeding not doing very well as we move on. Support for mothers to recognize and respond to infants' cues for feeding. Those are very basic things, but very important. How many court deaths have we even had because a baby mother was not careful to know the last breastfeed was at 4 a.m. Now it is 8, 9 a.m., no breastfeed, the baby is still there, the baby is asleep. And so many of these things end up being causes of our poor neonatal, our high neonatal mortality. The council linked them on mothers on the list of bottle feeding, just to note that we've noted we are going higher on bottle feeding in the country. The teats have become the order of the day. The pacifiers are kind of related to urbanization, so we should be careful that the mothers are getting the right information. Coordination of discharge, the community level support, and the ongoing support and care is where we have a lot of work to do as a country because the community level support is quite inadequate. And where it is about those people who are taking advantage of the lack of knowledge to give the knowledge in the wrong direction. So a mother is a member of a mother-to-mother support groups where a mother is now showing them the most recent infant formula that is marketable, and there's a machine that can help you mix. You don't have to measure the water yourselves and all that, the social media marketing. And so they have invited people into different groups. Let's be careful on what we are. So allow me not to work on this because I can tell time is not on us, but I just want to say that the health system, the healthcare workers may perform inappropriate procedures that interfere with breastfeeding, and a number of them as stated. And the barriers to skin contacts, most of them are related to common practices rather than to medical concerns. So how do we ensure that our healthcare workers are careful on what they do, that they may not hinder the skin-to-skin contact? This is, for me, is one slide that I should not have lived without saying, because I just felt, so what next? Just to say that for us to do BFHI in this country and in other countries, there's no one strategy that is fit for all. It's about everyone assessing their situation where they are, because the resource setting is different, and the abilities, the capabilities, the opportunities for training, the opportunities for competency building is all very, very different. And then you innovate. Surely, if every one of us took it upon ourselves to do something about breastfeeding, with the various innovations that are within this room, we would reach maybe tens and thousands of people. So innovate what is practically possible. Is it about your social network? Is it about your work? Is it about groups? Is it about what works for you? That becomes very, very important. Is it about the health facilities where you work? Because I've seen cases where health facilities have performed exemplarily well. I would give an example of a health facilities in one of the counties in Kenya where we had a dispensary that used to deliver 2 mothers in a month, moved from 2 mothers in a month to 64 mothers in a month, coming to deliver at that dispensary. Why? Because the healthcare workers was very positive and gave the information. So with time, that facility was having more deliveries than the county health facility, because mothers preferred to come and stay in the neighborhood so that they can go and deliver there. Of course, that just means there's somebody who was there to innovate and also to develop what was required to support the mothers so that they can do the breastfeeding. Ensure you engage, because you cannot serve a population unless you engage them. So they give you the best ideas for that. And then what you learn, can you also devolve it? Be a sphere of influence by ourselves so that we influence more and more to support breastfeeding. You can get more on this. I shared this because I thought it's one of the medals that can really work for our country, with very clear feedback groups, because these are very, very important. So if you are struggling, there's a way you can assess, you can innovate, you can develop, engage, and evolve. This is very, very important. Thank you so much.